So, good afternoon. Thank you very much for being here. And as you noticed, we're building up momentum to one of the greatest sessions of the meeting. Together with my friend Tim Resch, I have the honor to moderate this session. And we have really giants of endovascular and open surgery in this session. So don't leave before the end. There are a few industry-sponsored symposia, short industry-sponsored symposia built into the session, but we're going to continue with the scientific content right thereafter. And we start with Caitlin Hicks from Baltimore, who's already on her way to the stage to tell us about differences in outcome between IDE centers and other centers in complex aortic repair in the US. Please, yes. Caitlin.
Great, thanks so much. It's a pleasure to be here, and welcome back after lunch. I'm going to be talking about outcomes in centers with and without an IDE, which is a little bit of a specific thing for America, but it has broader implications related to both volume and regionalization of care, which I think are very relevant to this audience. So these are my disclosures. I'm going to start here with a case. 82-year-old female presents to our hospital complaining sort of vaguely of back pain, gets the CT scan and the ED sort of as always, and it looks like this. As we track down, you can see sort of an ugly-looking pararenal aorta there. Now with some clot extending just above the celiac, sort of a large infrarenal component to this aneurysm, about 6.3 centimeters in maximum diameter. A little bit of small iliac access here, although she's quite a big lady, if you can tell, about 110 kilos. And so I think sort of the vessel size is relative to her size and has all the standard comorbidities, COPD, diabetes, coronary artery disease, and obesity, as I mentioned. So things to think about this. I work at a center. I'm at Johns Hopkins. We are a high-volume center for complex aortic repair, both open and endovascular, but we do not have an investigational device exemption or an IDE. So how do we treat this patient? What access to devices do we have available? Something to think about. Should she get open surgery? Should she get endovascular? Where do we treat her? Should she be treated at our center? Should we try to send her 2 hours up the road to one of the ID centers at Penn? And when to treat her? Is this really truly urgent? Is the back pain actually related? Do we have time to get her something built as a custom-made device in one of those ID centers? Lots of decision-making to be had. So within the United States, fenestrated and branched EVAR, we have sort of 4 choices. You've got ZFen, which is not, it's a juxtarenal device really, not really a thoracoabdominal device, but it's present. And we have TAMBI, which just came on the market in 2026 of January, so is relatively new for people. We have physician-modified endografts, or PMEG, which is done pretty broadly, and I'm going to talk a lot about that. And we have CMD, or custom-made devices, which is only accessible to specific IDE sites. And PMEG, in theory, should be only done at IDE sites, but within the US, as you'll see in this data, it's actually done quite more broadly than that. So what is an IDE exactly? It's regulated by the US Food and Drug Administration, or the FDA. Any device that is considered to have significant risk, you have to put in a protocol with a proposal. It's very carefully curated, the types of patients that you enroll, the types of procedures that you're allowed to do on them, the various criteria, and then your outcomes tracking is very carefully watched by the FDA, and you are allowed to publish on the outcomes if you have an IDE, although since you should not be operating without an IDE using PMEGs or custom-made devices, you really can't publish on it because it will sort of raise awareness that you're doing something that is technically against regulations. So what are our data? Well, the FEVAR and the data from the US sites has been pretty proudly published by the Aortic Research Consortium, or the ARC. This is a complex of mostly sites that have access to custom-made devices, so really doesn't contain PMEG studies, but has really been instrumental in changing the field of fenestrated and branched endograft technology within the US. We have a little bit of data on PMEGs, even though you're not supposed to publish on them if you don't have an IDE, because some of these do get entered into the Vascular Quality Initiative, or the VQI. The problem with this is that no IDE cases are contained in the publicly available version of this database, and it's not nationally represented, so you choose whether to participate and whether to report in this, so we don't really know what's going on in sort of the broader community. So overall, we really have no sense then of the prevalence of FBVAR in the US or the center-specific volumes, which we know matters, and the perioperative and long-term mortality rates for patients treated with or without an IDE are really not clear. So how can we study this? Well, we have access to this sort of unique Medicare database. Medicare is the national health system that covers all adults over the age of 65 years old and those with chronic or severe kidney disease and other chronic disabling conditions. And we also know which sites have IDEs because these are all registered in clinicaltrials.gov. And then by definition, we know which sites don't have IDEs because site-specific and physician-specific data is included in Medicare. And so we can look at that to understand exactly what the trends look like in the USA, and they look overall out like this. You can see here the no IDE sites is in the gray, IDE sites is in orange, and there's significantly more cases performed in non-IDE sites in the US. In 2023, about 900 cases performed in that year, compared to about 350 cases performed at an IDE site. If we look at what this looks like in terms of volume, however, really low volume. So overall, median in IDE sites, about 22 cases performed per year. But in these non-IDE sites, it's really 1.2 cases per year. So this is sort of a one-off. They get a patient coming in, they're doing a PMEG or some other version of a fenestrated and branched EVAR. And so do we really think that the outcomes between these two sites can be equivalent? And in fact, they are not. So this is 30-day mortality, probably not surprising here. Hospitals without an IDE site have about 30-day mortality about 5% compared to 3% to those with IDEs. Interestingly, if you follow this out to 3 years, these curves ultimately do come together and it's no longer significant because frankly, all these patients are sort of dying. We've got about a 27, 26% mortality rate here, suggesting these patients are very sick, which we do know. After adjusting for a variety of patient factors and physician and ID-related factors, 30-day mortality is about half that at hospitals with an ID compared to those without. And the mortality benefit does persist long-term, but it's entirely driven by that original 30-day mortality. As I mentioned, it sort of comes together, and if you do a landmark analysis, this entirely goes away. So that, the way that things are coded in the Medicare databases is using current procedural technology codes, which just codes for fenestrated device by numbers of vessels. So you can code for 2, 3, or 4. Obviously, there are commercially available devices for 2 vessels and 3 vessels, the ZFEN. So if we look specifically at 4 vessels, we know that these are PMEGs or custom-made devices because no other commercially available device was available up through 2023. TAMBI we did not yet have. And you can see here, ultimately, these trends are the same. So 2.4% in ID sites, 5% in non-ID sites at 30-day mortality, and longer term they come together with mortality rates closer to 30 to 35%. So what are the differences here? Probably something related to volume, right? We know that the ID sites are doing way more cases. Probably something to do with patient selection. The ID sites are much more careful on who they're operating on. They need to have good outcomes. The devices may be better in those ID sites. Many of them have access to custom-made technology, and a lot of the things are protocols in the ID sites because you're really being careful to report on things, and this may have an impact on long-term patient outcomes. So I can tell you volume matters. This is a study that we just did, which is currently under review, a little low-S plot looking at derivatives for when the mortality curve changes, and it changes here at 9 cases a year. And if you plot this back in sort of a more standard fashion, you can see here mortality for cases doing less than 9 cases a year, between about 5.7 and 5.8%, and then it steadily declines after that as you do in more and more cases per year. Looking back at this center-specific volume curve, high-volume cases, about 74% of ID sites are this, whereas non-ID sites, only 7% are considered high volume, so really not for doing many cases at all. But if we go back and look at that analysis, specifically within high-volume centers, IDE status is still significant. So there's still something with the IDE that's not exclusively related to volume, but ultimately is important. And so can we just increase education to disseminate the branch and fenestrated technology? I think ultimately probably we just shouldn't. Maybe there should be regionalization of care. There's no way for community hospitals that are seeing 1 to 2 patients a year getting good care, getting good outcomes. These patients should be shipped to a main campus that can actually do these cases with high volume, high fidelity, probably an IDE in place, and ultimately will serve our patients the best. So this specific patient, it was unclear what her back pain was for, couldn't really figure it out. We ultimately did end up doing a PMEG for her. This is a 3-vessel PMEG because her celiac was occluded at the base, and ultimately she did well. But certainly we are doing this off ID, and it's definitely not something that we would recommend except for in sort of extenuating circumstances. So I'm going to end there and open for some discussion.
Thanks, Caitlin. That was a lot of data to take in a short time. I wanted to ask you, because I think the ongoing discussions on PMEGs versus sort of commercially made devices is constant, and we're a little bit different in Europe than in the US. So I wanted to ask you just sort of, if you had access to a commercially made device that was suitable for the patient in front of you, would you choose that as opposed to a PMEG, or do you think that the PMEGs are just as good as the commercially made device?
I think it kind of depends a little bit on the patient anatomy. There's probably some anatomies where the PMEG is going to do just fine. There's some anatomies that are more complicated where a custom-made device can really do you a lot of good. And so I think it's a little bit of a balance. And of course, urgency of need and things like that all play into it. But if we had access to custom-made devices, I suspect we would be going mostly with those and reserving use of PMEGs for urgent cases.
Yes, thanks for a great presentation. If you have a question or a comment, please raise up your hand. We have a running mic somewhere, and you get the mic to ask a question. While we're waiting, Caitlin, I think, how did you put it, vague back pain?
Yes.
That also doesn't sound like a very strong indication for an urgent
100%,
treatment.
yeah.
Yeah, but it sounds a little bit like the indications for type B dissections that, like untreatable hypertension, etc. But let me ask you something else. 5% mortality in non-IDE sites for complex aortic repair with PMEX does not sound terribly bad for my ears. I believe we have series where mortality here is very similar with standard devices. So can that difference 3 to 5% not just be a selection bias because these non-IDE sites are operating urgent patients and emergent and ruptured patients more than the IDE sites?
There's a possibility, but if you adjust for all those things, and I don't have time to show you the 8 million subgroups analyses we had in here, but ultimately, you actually, as you sort of hone down on the elective 4-vessel interventions, that difference in mortality, it continues to expand. And so I think in reality, although 5 versus, and it's really 6 versus 2, does that matter? It's a 4% difference. I mean, if you're one of the patients, it would matter to you. And so I think long-term it does. And I mean, this is just scratching the surface, right? This is sort of perioperative mortality. Hopefully we can get most of the patients through these types of cases. We haven't even begin to look at sort of reinterventions and sort of the other longer term consequences, which I think are really critical to this story.
You mentioned that, Andy has a question just before, turn around, Thilo, and hand Andy the mic.
I'm the running mic. No,
Yes, you're the running mic.
Start running, Thilo.
Come on, Andy. Come on.
Sorry, the only comment I would make, and sort of segue into a question, to me it's less maybe ID, non-ID, PMEG, CMD. It's just the shocking number of places that are doing 1 to 3 repairs a year. And to me, I think that's the biggest issue. So I guess my question to you, Caitlin, and it's not an easy one to answer, is in an environment where you're incentivized to do cases for productivity and subsequent revenue, how do we get our arms around that in the United States? I mean, the majority of centers in the US are doing 1 to 3 complex fenestrated branch repairs a year. I mean, that's just not a viable strategy.
I mean, the solution in the U.S. is actually quite simple because it is a fee-for-service medical environment, and so the answer is for Medicare and the other private payers simply to not pay for PMEGs, right? You do a PMEG on a patient because the patient needs it, but you're not going to be reimbursed. It'll stop happening really, really quickly. All of those patients are going to get transferred unless it's truly, truly emergent.
All right.
I think we have to continue, and you're going to announce the next speaker. But just very quickly, as a comment, Caitlin, if you would look at the data in Germany, you would be surprised that also the median number of complex cases done in Germany is also exactly 1.
Yeah.
So
it may not be such a big difference.
I think so.
Thank you very much, Caitlin. Big round of applause. So it's my great honor to present the next speaker. And Gustavo, I would have hoped you would have given me this presentation a week ago before the Brazilian ladies kicked the butt out of the Swedish handball team in the World Championships, because we're going to hear about strategies to avoid crushing defeat during FEVAR. Thank you.
And do I have the slide thing? Thank you, team. Thank you. Thank you. Yeah, I'm not even going to get to the soccer or football because it's going to be a disaster. Anyway, such a pleasure to be here. I know Stefan is not here personally right now, but I'm very, very pleased to be here on behalf of our team, and these are my disclosures. It's very humbling to do a fenestrated repair. You learn very early on that sometimes all that case that's going perfect turns into a disaster. All it takes is somebody to say, nice job, how great, you got into this renal artery, and then you dissect the renal artery. We look at that in our own experience, and about 1 out of 5 patients that we've done cases, and I think I'm a very slow learner, we actually had some sort of an issue with the procedure. These patients tend to do worse, particularly if you get into a fight with a renal artery, end up losing part of the kidney or have a lot of ischemia time. It does get a little bit better over time. I think learning and experience and all the tools that we have nowadays with better catheters, steerable sheaths, imaging, etc., made this go down. We also learned some of the things we have to avoid. It does seem to be more frequent in females, and they have a lot of predisposition for that, mostly small vessels, a lot of atherosclerotic burden, access issues, tortuosity. It's also more frequent with extensive aneurysms, and naturally those extensive aneurysms, you might have issues to get into the vessels. We're not the only ones that demonstrated this. This is another publication which highlights the fact that women tend to have more problems. These patients have higher mortality, and it's not only access issues, it's target vessels issues. So what are the most common problems we want to avoid? Well, fenestrated, as you know, has multiple steps and multiple components. So while we are doing one step, you want to make sure you don't cause trouble on the work that you already done by kinking and compressing stents. You want to be careful with vessels not to avoid dissection or perforation. You want to avoid misalignment of the stent. I think a lot of that is on the planning, to be frank. Learning the cases, you might want to do a branch or a retrograde, antegrade branch or a fenestration. You want to definitely avoid iliac access issues, so if you think you need a conduit, you should probably do a conduit. It's always best than dealing with that after. Iliac and aortic stent infolding or kinking is infrequent. We all learned that one of the most frequent issues we see is the issue that once you put all the fenestrations, if you keep crossing that with sheaths, catheters, or dilators, you might risk collapsing or compressing one of the stents, just like in the illustration, which if you don't recognize, will lead to a postoperative complication. I think the stents got better over time, not only in flexibility profile, but also radial force. This is work from Martin Austerman, demonstrating here that in terms of pull-out forces and radial force, really the bigger F plus and the VBX kind of win over the other two options. You can find this publication. This is an example of a case that I did where we looked on the combing CT, and you can see a little slight edge of the stent of the SMA. And if you see, that often affects the SMA or celiac anteriorly or the contralateral renal because of the angulation of the aorta. That dilator tends to dislodge anteriorly into the contralateral side. And if you don't recognize that, you might end up with an occlusion, like this case. This is a patient that they all came back post-op. We checked the CT scan. There is this SMA occlusion. Patient is asymptomatic. I still recanalize that. Or there is that renal artery that we end up losing the kidney. It was too late. So how to avoid this? I mean, Nuno Diaz described a very nice technique, along with others, the no-cross technique. Nowadays, we have the short tip dilator for the bifurcated device. That's a nice feature. If you're going to use steerable sheaths, avoid forming the sheaths around the stents. Work either above the celiac or you work below, but don't keep crossing the stents with the sheaths, because you can, even with the sheath, you can cause a kink. Combing CT, I think, is a very important feature. We tend to do routinely. We do it fast. It's not something that really affects our workflow. A little bit more about the no-cross technique, again, using the short tip bifurcated, and on the description here by Nuno and his group of using actually the gore limb, which has a very short tip dilator for the iliac limb extensions. And I think this is for the industry that might be hearing, the iliac limb extension dilators have to be shortened if we're going to do this. Guide wire management, that's very important. I think this with the SMA, keep your wire in the main trunk of the SMA. Avoid putting wires in small jejunal branches, because if there is any movement, you can easily perforate, and if you perforate, it can be a total mess. Here's another example of a perforation of a renal artery. If that happens, don't watch. These kidneys are going to form a pancake kidney. You want to embolize that branch. That may be done with a microcatheter, microwire. Of course, this is a disaster. Some of these perforations can't be salvaged. If you can't salvage a renal perforation, don't lose the wire access. In fact, one nice trick is to extend the stent into the retroperitoneum, and then you can pack that stent with coils or even an Plaster plug. This is an example of a dissection perforation of a celiac, where we did a very fancy loop technique with a microwire going from the SMA through the gastroduodenum all the way to the celiac, snared, and were able to salvage. So that was a nice save. A nice trick also is to use the IVUS to re-enter the vessel. If you already lost wire access, you can have an IVUS parked almost invariably in the false lumen, and with a microcatheter, try multiple times until you see that little dot in the true lumen, and then you can salvage. In the interest of time, I'm going to jump this slide. I think that, again, technology is getting better. One important innovation for industry involved in fenestrated is to make the steps easier. And that's what the B-Flare is, I think, going to add, and hopefully other stents as well, by allowing less movement, less exchanges, and that means less risk of perforation or occlusion. Combin CT, this is an example of a case I found out post-op that we had this infolded stent with a type 1A endo leak. Of course, we had to do a re-intervention. And I showed you this case. This you want to avoid, and you can avoid that by being meticulous with Combin CT. There's many different protocols. We tend to do actually one without and one with, which generates a rotational DSA that's very nice to look at the vessels and flow, but that I recognize is optional. And we actually demonstrated that once we did that, we almost cut completely the rate of avoidable reinterventions. Just to finalize, this is an example of a case I did an SMA stent. Angel looked very good, but on the Combin CT, I saw a small flap. I reinterrogated the SMA, and we saw this stop. If I had sent this patient to the floor, it would be a disaster. So in this case, actually, I opened the patient. I couldn't do endo, took the intimo out, put a nice flap, and the patient ended up doing very well. Softwares are getting better for the Combin CT. This is the new innovation of GE with the Clear Recon DL, which is really much going to improve the sensitivity. So in conclusion, be attentive to detail, use finesse, do your final assessment at the end, and be humble, because these fenestrated cases, you can easily have a complication, even though you think the case is going well and you are almost done. Thank you.
Thanks, Gustavo. I think we need to assign you more time next time, because you seem to have more interesting complications to watch.
Thank you. I'll take that as a compliment.
And any question? But tell me, Gustavo, out of your experience with these cases, you have a patient where you start with the reens, you have a full fenestrated case, and yet you get a dissection in the first renal that you're doing. How do you react? Do you change anything in your setup, or let's say your fellow gets a dissection in the first renal that he or she is doing?
I changed the fellow.
Is there any specific precautions that you're taking for the other target vessels?
Yes. Well, first I try to salvage that dissection, Thilo. It's always tough when you lose a vessel. So, but I think that, yes, that it's already an indicator that you can't do that mistake again, or that it might be the fragility of the vessel. If the patient has a predisposition to dissection, you try to learn a lesson from that vessel, so you're exceptionally careful on the next one. And this is the thing with fenestrated. I like to think about that guy on Cirque du Soleil with all the balls on that, if you can drop one and everything goes down the tube. So you have to be very careful.
Tim, how about you?
So I wanted to ask you about target vessels and complications. We used to put a lot of self-expanding stents in the distal. Do you have any favorite stents?
I don't do that anymore,
targets?
Tim. I'll tell you. There are so many of those self-expandable realignments at the distal edge that came back with intimal hyperplasia, or that if you try to cross with a balloon, the balloon doesn't go in and he ends up almost pushing the stent forward. So I don't do that. I do think, I'm very careful about not oversizing my bridging stent. I usually go nominal, deploy, and then when I flare, I check, but I don't like to oversize too much. I think you have a little risk of dissection or neointimal hyperplasia.
And I just wanted to also ask you, any specific strategy when you have patients with connective tissue disorders for the target vessels, self-expanding, balloon expandable?
Yes.
Where do you go?
Yeah, I would like to be using more self-expandable for the connective tissue. I think that I've had several examples with radial force, the vessel almost enlarged around the stent. But most situation is here now branches, not fenestrations. And I mean, the reality is that profile of balloon expandable became so appealing with 6 French, and the steerable shifts are still not ideal. I think that that's going to change very soon with a new 12 French steerable shift that will be a game changer.
All right.
Yeah. Tim, we need to do better with the audience. We're not getting any questions.
They're sleeping.
No, I don't
You got to
think
wake
so.
them up.
You just need to look more careful.
Did you push the button?
Okay.
Okay, let's push the button.
Thank you very much, Gustavo.
Thank you.
We're going to move on, and we're going to ask Eric to step up on stage and talk about how I designed my FEVAR, a lesson learned from 2,000 cases to achieve a successful repair. Eric.
Yes, thank you very much, Tim. It's a pleasure to be here and discuss that. And as I have to debate Gustavo Odrich tomorrow, I thought I already use a few of his images in this presentation to get used to it. Now, with regard to this presentation, my disclosures are clear. I use different fenestrated and branch grafts, but it's fair to say that more than 95% are from Cook. If you look at the title that was given to me, obviously the more than 2,000 includes all the fenestrated and branch grafts. And I will also not discuss execution. I will only discuss some planning issues. It seems like an easy presentation when you've done more than 2,000 cases, but I have to remember that I'm getting older and that I started in an era where we only had fenestrated grafts and the branches came later. And we all know that branches are more forgiving, and we all know that it increases our option. So the answers to the question that were posed to me in the title are really: don't be dogmatic and choose the best option for your patient. I think that's very important. As Gustavo already said, please respect the basic rules and also know all your options. I think that's very important. So if we go back to fenestrated EVAR, I think it's fair to say that we want the graft at that level to be in contact to the aortic wall. Therefore, the indication is in most complex abdominal aortic aneurysm and maybe also in a small proportion of extent for thoracoabdominal aneurysms. And if you look at this image, I'm almost contradicting myself because here the graft is not in contact with the wall. So maybe this is a much better example of a full fenestrated graft where you have a very long sealing zone that you can appreciate and where you see clearly that all fenestrations are against the wall. Branched EVAR, fairly easy, and that's a perfect image to illustrate it. We have a long distance and we have gaps to bridge, so most thoracoabdominal aneurysms are suitable for this type of branches. And here an example, you can see that it's not only the gap, but also the angulation of the target vessels that plays a very important role. And here, nowadays, nobody would dream of using fenestrations anymore. So we also published on that a couple of years ago. Thanos is sitting there. And I'm showing this because with time, things changed a little bit. We obviously said in the old days, for renal artery, you need a 90-degree takeoff. We don't need that anymore. We catheterize from below, mostly yes, but not completely. And the graft needs to be in contact or close contact to the aortic wall. I think we should add to that nowadays that a fenestration should be in a healthy portion of the aorta to prevent extension of disease and target vessel instability. Invertedly, to discuss the evolution again, branches are there for sharp takeoff vessels. They are catheterized from above. We know that that has changed. And you need enough space. Well, that has changed too, because we now have inner branches that can accommodate different anatomies much better. And the one paper we contributed to that paper that discussed fenestrations or branches for renal arteries is the paper that was done under the lead of Stéphane Holland's group. And this paper showed clearly that renal arteries don't do so well with branches. But there is obviously an enormous selection bias in this paper because the branches were used for more complex, read thoracoabdominal aneurysms, and the fenestrations for less complex, read pararenal aneurysms. So the one thing I take from this paper is if you have a renal artery target vessel that is suitable for fenestration, don't use a branch. The evolution that I discussed a little bit already is first the inner branches that give us an extra option for target vessels that are not so suitable for either a normal branch or a fenestration, as discussed before, but also that we can put indwelling wires into fenestrations and then catheterize them from above. That is sometimes a very nice option. And as discussed before, we now have steerable sheets. I know Stéphane uses them even in fenestrations. I don't do that, but you can do branches from a femoral approach. And we also have fenestrated and branch grafts that include both branches and fenestrations or inner branches and fenestrations. And here you see a very nice example of a large aneurysm that came to us. And in this anatomy, I would rather prefer a CMD graft with 2 branches for the visceral arteries and 2 fenestrations for the renal arteries. But that brings us to the balance between a CMD graft and a off-the-shelf graft, an off-the-shelf solution. And we have off-the-shelf solutions. We have the T-branch, we have the PMAG, it was discussed already, and we have in situ fenestration. So you have to balance all these options in your patients. And to a certain extent, we know that off-the-shelf solutions start higher than CMD solutions. So you have to balance the risk of paraplegia versus the risk of rupture due to the CMD delay. To finish, something about the choice of the proximal sealing zone. This is already a 10-year-old paper where we made clear that we don't use double fenestrated grafts anymore, but we like to go higher with triple and quadruple fenestrated grafts to have a longer sealing zone, to have a more stable position in the aorta. And you see it here. The basic rule of a fenestrated graft is to create a long sealing zone in healthy aorta. And if you use a 4 fenestrated graft, you don't only create the best sealing zone, but also have a nicer and easier extension if it would be needed at a later stage. I think triple FEVAR is not out. This is a perfect example, but you have to take into account that your sealing zone needs to be long enough and that you don't have any dilatation of the thoracic aorta that may have you come back at a later stage. So to conclude, I think, first of all, know all your available options, and that comes to the N is 1 per year. That should not be allowed. I think you should choose the correct graft design for your patient and not for yourself or the hospital. I think you have to balance all the pros and cons as discussed and appreciate the technical adjunctive options when you are using off-the-shelf devices in an anatomy and it doesn't fit so well. So there you will need more technical adjunctive options and more technicalities to make it work. Thank you very much for your attention.
Thanks, Eric. Great talk. We have 4 minutes for discussion before you continue speaking on behalf of Bentley, but we have a few questions. Andy, over.
Great talk, Eric. Great experience. Could you comment a little bit on where you've currently landed with your thinking on internal branches and then upgoing branches? When are you finding those are useful currently?
Well, to start with the second one, upcoming branches should be reserved for very special anatomies, and that may be an upwards target vessel that is specifically behind a kink, where you can make it much easier, and then maybe use a very flexible, maybe even self-expandable stent to bridge the gap. With regard to inner branches, you know, I came up with that idea in 2004, and it took a long time for Cook to accept the idea to also have inner branches in visceral arteries. And we were allowed to start it together with Marcello Ferreira, and Cook made it very clear that we needed a good publication before it would be opened. I think inner branches should not be seen as the next hype. I think they are being used in target vessels that are not very suitable for either standard option fenestrations or standard branches. And then maybe, and I will discuss that later, the bridging stent graft plays a role. But you end up using them mostly in thoracoabdominal aneurysms, and we know from previous literature that the renals don't do very well. And I don't think they do much better with inner branches than with outer branches.
Eric, that was a great talk. You have a lot of experience, and you published also on the risks of interval rupture where we wait for these CMD designs. So I just wanted to ask you, if you have a patient come in with a 7-centimeter aneurysm that is pararenal, what are the 3 key points that will push you over in that 7-centimeter aneurysm, or 6.95, to using a CMD versus using an off-the-shelf design? If you, in your mind, if you just break it down, because I think that's a recurring theme.
I get nervous when the patients have an 8-centimeter aneurysm. In the north of Europe, where the people are somewhat taller, 6 and 7, I would try to have a CMD if the anatomy requires it. That's a very important point. If you can do, we did a T-branch, I will show it in a minute, on a patient where the anatomy allows for a T-branch without moving much higher or without having too many technical difficulties, then we would go for an off-the-shelf solution. But if the off-the-shelf solution is really bringing new risks into play, like paraplegia, we would either do a normal CMD and then do it urgently. I measure my fenestrated cases myself, which means that within 24 hours I can order the graft. I would then ask Cook for an urgent order, and usually we have it in 3-4 weeks. If we can't, we will do a PMEC. It's not something we do regularly. We do it occasionally, to be honest, but a PMEC is then the next solution. And Thanos published it and discussed it. It's interesting to see that we wait, let's say, 6 to 8 weeks for fenestrated CMD grafts. And in the big centers, Thanos, you have to tell us which centers, we wait another 9 weeks to schedule the patient with the graft already in the hospital. Now, obviously, with the larger aneurysms, we schedule them immediately.
We have a final question over here.
Yes, Eric, is there a reason why you used only steerable sheaths for BEVAR and not for FEVAR? Is there maybe a higher chance of risk for dissection of the target artery using steerable sheaths with BEVARs?
I don't think so, Eric. It's also an Eric. Yes. So, you know, I've been used since so many years, it's 25 years now, to do fenestrated grafts, and I think the A&O about, or the ins and outs about fenestrated, make me move my graft a little bit for each target vessel. So if you have 2 doors and you want to go through the 2 doors, both doors need to be open. So you have a hole. If that hole is not in front of the ostium, you can catheterize as long as you want. And so please, I organize my C-arm, or I orient my C-arm as I measured my target vessel. I move my stent graft a little bit to have all 4 markers aligned, and then I try to catheterize. And I think that makes it much, much quicker and obviates the need for steerable sheet. Now, if you prefer, like Stéphane Hollande, to use one steerable sheet for all 4 target vessels because you have far more stability and you get in easier too, fine with me.
Thank you very much, Eric. So next speaker is Andy Schanzer from University of Massachusetts, who will tell us about creative fenestrated branched EVAR solutions in redo cases after EVAR open surgery. Please, Andy.
Great. Thanks, Thilo. And thanks again for the opportunity to be here. And this was a really fun presentation to actually put together. These are my disclosures. So first, I'll start by saying if you're looking for data in this talk, this is the wrong talk to be at. There will be no data. Really, this is to show you why I think this is the best job in the world. And when Stéphane asked me to talk about sort of creativity, I thought about these different French masters, and certainly I don't claim to be anything like that. But I would say that one of the reasons I've been attracted to vascular surgery is because of the creativity involved with solving some of these problems. So let me start with some cases. So this is a 65-year-old man, type 2 thoraco in 2010, had a Correll patch for the celiac SMA and right renal and a bypass to the left renal. And then 6 years out was found to have degeneration of both the Correll patch and the intercostal patch. The saccular patch aneurysm was 6.2 and the intercostal patch aneurysm was 5.1. And this is just the 3D reconstruction showing that. So the way we approached this was with 3 branches and a fenestration. And you've seen cases like this before, but this is on our old system because it's an old case, left renal fenestration, then the right renal branch, the SMA branch, the celiac branch. This patient stayed in the hospital overnight in the ICU, then went to step down and was discharged home on post-op day 2. And I'll show you just one more image. This one now is 9 years out, and you can see that it's a very stable reconstruction. We've now done 11 cases of this exact variety. I'll just show you one more. This is a 74-year-old with a type 2 in 2008. Same reconstruction, now 7 years out, found to have a saccular aneurysm of the patch measuring 7.6 centimeters. So again, you'll notice really the same type of design. So 3 branches for the celiac, SMA, and right renal coming off the patch with a fenestration for the left renal. Again, here you see the standard images you're used to seeing, the left renal fenestration, right renal branch, celiac and SMA branches. Again, ICU overnight, our step-down unit post-op day 1 and sent home on post-op day 2. So nice kind of construct, and this one now has 11-year follow-up. So what other type of designs? Well, this was sort of an interesting case. This was a 78-year-old woman who presented to our clinic for what was called a thoracic aneurysm. Of note, 25 years ago, at age 53, she had undergone descending thoracic to infrarenal aortic bypass with grafts to the bilateral renal arteries for a middle aortic syndrome. This was complicated at the time by thrombosis of the right renal bypass, necessitating a right common iliac to renal bypass, and had a several-month hospitalization, which she ultimately recovered from. So this is how she presented to us. So you can see the descending thoracic to infrarenal bypass, as well as the graft to the left renal. And you can see that there's a pseudoaneurysm. So we evaluated that patient at 2018. It was 4.9 centimeters. We decided to just observe that. It was stable at 4.9 centimeters the following year. Again, 2 years later, now 4.9, but then a sudden large jump to about 6 centimeters. She was not willing to undergo any conversation of a repeat open repair and was quite traumatized from this previous open repair she had had. So this is what her anatomy looked like. Again, I'll just point the celiac and SMA are coming off the native aorta right above the constriction from this middle aortic syndrome. And then you can see the surgical graft with the left renal bypass. So we came up with a design where we would use a branch graft from the native descending into the surgical graft with branches for the celiac and SMA. We then extended that with a single fenestrated tube, and that had a fen for the left renal. So this is what that design looks like schematically. Here you can see we've got the branch graft deployed so that the branches open above the native aorta, allowing access to the celiac and SMA. Here we have the celiac and SMA cannulated through those branches. Bridging stents were deployed to the celiac and to the SMA. We then open this fenestrated tube below that where we can cannulate the left renal artery and bridge that stent graft. And then knowing there would be a type 2 endoleak coming into the pseudoaneurysm from this middle aortic syndrome, we put plugs to occlude that. And then this patient was extubated in the OR, was in the hospital a couple of days, and has now a 5-year CTA showing the graft intact, no endoleaks, and that pseudoaneurysm has regressed from 6 to 4.2. So another interesting kind of open fix. So this is a hybrid patient. This patient was a 72-year-old. She was referred to our clinic for a type 1B endoleak. So 11 years prior, she had had a hybrid repair. This was a type 2 thoraco with a TEVAR from the left subclavian to the infrarenal aorta, and the visceral aorta had been completely debranched. Unfortunately, during this open hybrid operation, she developed perioperative end-stage renal disease and had been on dialysis for the last 11 years. So this is her construct. So you can see she presented to us already 11 years out from this long TEVAR with the visceral branches you can see debranched off of that terminal native aorta. Unfortunately, that terminal native aorta had now dilated, and you can see there's a very large type 1B endoleak at that site. So just to show you kind of the anatomic challenge, you can see that there's the SMA branch coming off, celiac was occluded, and there was a right renal branch, although I'll just remind you the patient had been on dialysis. So the challenge there was working with the aortic bifurcation. So we came up with using this design, which was a bifurcated endograft with a custom size so that we could incorporate a large fenestrated limb. We wanted to have a large fenestrated limb that could accommodate the aortic bifurcation, but also provide robust blood flow to the SMA. And we wanted an 8mm fenestration for that. So you can see here, this is kind of a conceptual drawing of the diagram. So this is in the operating room, so we gain access to the right renal, very straightforward, and then put a plug into the right renal to occlude flow there to avoid a retrograde endoleak. We then put in the bifurcate, and you can see here we've got the fenestrated limb, and we'll work through the fenestrated limb, which was preloaded, and able to get into that SMA relatively easily, put in a bridging stent graft, and preserve flow. So this patient was in the hospital just a night. She now has a 4-year CTA, her graft's intact, she's got no endoleaks, and her infrarenal aorta has regressed from 6.2 to 5.4. So the last case I want to show you is in making, and this is a 79-year-old man with progressive growth of a type 2 thoraco that's now 8 centimeters. This is what that looks like. So you can see the 8 centimeter type 2 thoraco, but what you'll also notice is that the aortic arch has had a failure to fuse. So you can see that the posterior arch gives rise to the right carotid and the right subclavian. The anterior arch gives rise to the left carotid and left subclavian. This is what the schematic looks like, really no seal zone within that descending thoracic aorta, distal to the arch. So a closer look at that arch, you can see that actually there's a pretty decent seal zone for a TEVAR in that posterior arch, and it's about 4.5 centimeters long. And then the anterior arch, there's an area that's about 18 millimeters that we believe we can occlude with amplots or plugs. So the plan for this patient is build down with TEVARs after plugging that anterior arch and then using a branch fen device that looks like this. So a TEVAR from the posterior arch to the celiac, plugs in the distal anterior arch. Stage 2 is a branch fenestrated repair with branches for the SMA and celiac and fens for the renals, and a bifurcated graft in iliac limbs. So if you have me back next year, I'll tell you how that went, but I very much appreciate your time and attention. I think in conclusion, fenestrated branch DVAR has now evolved to the point where more often than not, we can design a solution to custom fit a problem. It doesn't mean every patient should get this, but I think it is helpful to think outside the box. And this creativity and thinking outside the box, I would say, is sometimes much more important than being technically excellent. So thanks very much for the opportunity.
Thanks, Andy, for sharing these great cases. I was actually expecting from the title something more simple. And so let me ask you something more simple. If you have a more standard case, like you have a standard EVAR with a type 1A endoleak, we discussed this a few times already in this session. So what is your preferred design for a renal coming off the bare stent region of a failing graft? Is that a fenestration? Is that an inner branch? How do you deal with that, and do you accept any distance between the graft and the
so I think first of all, that's a really common problem now. As you know, 22% of our cases, of the 700 cases we've done, are for failed EVAR. In the Aortic Research Consortium, which is now over 4,000 cases, 18% have done after failed EVAR. So the way I really think about it is depending on the size and trying to minimize any potential gap distance. So if it's most commonly, which is just an inadequate proximal seal zone, with a normal area in the visceral segment, I'll use a 4-fenestrated device with an integrated bifurcate, and I think that's a really nice solution. If there's dilation of that visceral segment, then I'll use branches, and really the concept is to try to minimize any potential gap between a fenestration and the target artery. The one other thing I always do, I always go above the bare stent, because I think you need complete apposition against normal aortic wall, and we always reline the entire endograft.
Thank you. We have one question.
Great talk, Andy. Really cool solutions. I was very impressed that you send the patients very early home. Do you think differently in redos, if everything goes smoothly, that they are already staged and you can send them home, or do you, because sometimes we want to keep the HB and the pressure high the first 2 days at least?
Yeah, so I think definitely in the setting where we're concerned about spinal cord ischemia, then at minimum we keep them 2 nights, because they spend 1 night in the ICU, 1 night in our step down, and then usually by the time they're ready to go home, it's that 2nd day or the 3rd day. In these cases, you'll notice most of them were already all covered, so there's really not an increased spinal cord ischemia risk. It's more just the technical exercise of whether we can get them through that acute repair. So I think that's why you saw these patients going home relatively quickly.
Very good. Any further questions?
Just wondering, do you ever use or ask for pre-cannulation of the branches, and do you ever find that useful?
Yeah, so it's interesting. We used to do a lot of pre-cannulation. We've largely gotten away from that. We just haven't found it's as helpful as we thought it was when we were using just directional catheters. So we, unlike some of the speakers you heard today, we tend to use steerable sheaths for almost everything now. And that has increased the sort of technical ease. I think one area where preloaded vessels, preloaded target artery, either branches or fenestrations can be helpful is if you're doing a redo where there's a lot of metal, and it can help to get out the fen to start by having preloads. But largely we don't use them, and we tend to use a configuration where we just use 1 steerable sheath, and then we leave wires in a stable position in each target artery.
Andy, thank you very much. Brilliant. Thanks, everybody.
Yes, and now it's time for the highlight of the session. As last speaker of the session, Professor Roberto Chiesa will come up on the podium, global expert on open TAAA repair. And please tell us when to use open repair still in TAAA, and maybe more importantly, when not.
Thank you very much. Thank you very much for this kind invitation. Thanks to Stefan for to be in Paris. And today here I am really an alienus on the art, because I have the first and the only that speak about open surgery. And I try to show you how is importance today still open surgery. My disclosure. And here the seasoned expert, you can see, and this is my last open operation 4 days ago in Milano. And this is my first operation, 20 April 1989 in Milano. So in 36 years, the lessons learned are on more than 1,200 cases of open surgery on thoracoabdominal treatment. But what really counts at the result. How to obtain good result in thoracoabdominal aneurysm? 3 main topics. how to balance open and endo, patient selection, and the surgical technique. Since the endo entered in our surgical theater, in our operating room, completely changed many things in the world, you see. And also endo rapid distribution in the world, rapid evolution, you see, from the first endoprothesis of Schutter till the new fantastic endoprothesis. And Gustavo said also some days ago and today that fenestrated and branched EVAR has become the new gold standard and is the first treatment option today. So today, should all thoracoabdominal patients treated by endovascularly? No, I think no. I think no, because there is some possibility to use also open. This is my experience. This is the paradigmatic treatment in my department. You can see that there is a large increase in the endo, but remain very important the part open surgery. Now the number 2 points, the very core of my presentation, the patient selection and contemporary indication to treat open today. Some patients are 3: young and fit patient, patient with genetic disorder, open conversion after TAAA, FEVAR, and BEVAR. Young and fit patient. Many tools to evaluate the fitness. What means fitness? Standard test, Frailty test, sarcopenia evaluation, but it's very important to understand that fitness for thoracoabdominal open surgical repair might be unquestionable. Otherwise, you opt for endo or no intervention. Other very important situation for open surgery, patient with genetic disorder. The argument is absolutely important for open surgery. Open conversion, typical endoleak, large increase of the aneurysm, opening of the aorta, removing, clamping, and removing on the prosthesis, and the substitution with Coselli graft, with reimplantation of all abdominal and distal vessel. Third part, surgical technique. You learn progressive from 1989 with a progressive introduction of several junts. You see, left heart bypass, custodial for renal protection, motor and evoked potential to study the spinal cord, rotem, and so on. And with this new technique that we employed in our patient, I want to show now our result. In this long period, 1,200 patient open repair, and you divide this patient in 2 main groups. First group with only selective use of this adjunct, and the second group with systematic use of all the adjuncts. And you obtain a big difference. The patient with use of the adjunct significantly lower 30-day mortality and permanent spinal cord ischemia. And so you can divide the group, and you see that 35% of mortality decreased to 75%, and the permanent spinal ischemia from 12% to 7%. Another and the last very important tool, and this surgery is not for all, and are a direct rapport between volume and outcome of this surgery of the patient. In conclusion, Mr. Chairman, ladies and gentlemen, I think that in experience of the aortic team, thoracoabdominal open repair still offer good outcomes. Indication repair have become more limited respect to open, but still extremely important. And now the patient selection. organ protection strategy using a shunt, play a central role. And after this, open and endo, I think that today are both used for managing complications that may arise from one approach or from the other approach. And today, open and endo can work together to offer the best option for each patient. And at the end, I invite everybody to Milano for the aortic surgery in December 2026. Thank you very much. The only one speaking. The only one speaking of surgery.
The only one speaking, but we saved the best for last. Was the case. So thank you very much. So in your experience, because I saw that your volumes are obviously very impressive over the years, but the volumes overall have dropped the last couple of years. You did a lot 5 years ago, and now the volumes are large. What do you think this drop in? But
the drop, the very important drop on open surgery during the COVID period. During the COVID period, I don't do. It was not possible to do open operation. For the other period in my department, you have a stable period treatment and increased absolutely the endo. But you have a stable period of open treatment because you have the opportunity to treat a lot of patients with genetic disorder, with genetic disease, and I think that you are the most important center in Italy to treat the complication of endo, the bad evolution of the endo.
Any questions? Yeah, Andy.
That's an amazing experience. Thanks for sharing it. The question I have for you, as you see these numbers decrease at your center and globally, what are your thoughts on how we continue to make sure that we disseminate this technique and skill set as we do less and less of these? And I know the answer is regionalization, but I worry even about regionalization at a few centers in a given country.
Yes, yes. Thank you for the question. I think that this surgery is today very, very reduced. It's reduced to a short, a very small number of the center. And I think that because this is very, very difficult surgery, you need a very strong team anesthetist, cardiologist, team for intensive care, transfusionist, extracorporeal circulation, and so on. So to have a very, very large and important, differentiated team, I think that it's possible to have only in few centers, like in the United States, like in Europe, like so. And I think that is always better because you have increase of the ability, you perfection or work or activity for this type of surgery. I think so.
Tilo.
You have no voice.
You're out. Well, it's a relay. We do this all the time. It's called the dance. Here you go.
Okay. So, Roberto, this was an excellent presentation, and I appreciate mostly also the last slide with your words of wisdom, that this is not competition, but these techniques have to work complementary. I think when it comes to when to use thoracoabdominal, it's all about who is a young and fit patient. I would like, if there are no other questions, I would like to make a short experiment with the auditorium. Is everybody awake and fit? So I would like, and this has become more relevant to me because I'm getting into an age where I'm like in between there. So I would like everybody here in the room who feels he would be a young and fit patient when having a 6 centimeter thoracoabdominal aortic aneurysm, who thinks he's a right candidate for open surgery, to stand up now. Who is young and fit enough to receive open surgery?
You see a lot of people, eh? Tilo, a lot of people.
These are all your
fantastic candidate.
Look, Gemma, you sure?
Candidate. Fantastic idea. And
Okay.
mainly men.
Yes, yes,
not
yes.
women.
Can you sit down now? I think we gave it enough time. So I would like to know who feels that he or she is not fit enough for open surgery to receive an endo repair at your age with a 6-centimeter thoracoabdominal aortic aneurysm. And I keep standing. So I think you...
One.
Wonderful. Thank you
One.
very much. You're
Why?
saving endovascular surgery. But it's amazing to see how well aware everybody is of the benefits of open surgery.
Yes.
Yes, very good. Thank you for bringing that to our
Thank you
attention.
very much.
Thank you very much.
What a pleasure to be with you. Pleasure. Thank you.